Hotbed Talk.
And if I can introduce Stefan, who's a medical doctor and has a PhD in exercise physiology and prehabilitation, works in the Maxima Medical Center in Eindhoven. And interesting fact, I'm sure he won't mind, he's 6'11". Unbelievable. Over to you.
Thank you very much for this kind introduction. So these couches are here to sit down when you're tall, right? No, I wouldn't be that lazy today. I will talk about money, and thank you for the trust to have me talking about money, because I'm just a medical doctor. I'm not an economist. I'm not a manager. And if you know me personally, I like to spend my money. And if you know my wife personally, she's here in the room too, she likes to spend money too, rather than saving it or thinking too much about it. And when looking at prehab, we think the sky has no limit. We should invest as much as possible to get that rolling, because everyone needs a good preparation. But in the past years, when I did my PhD on prehabilitation, I wasn't able to ignore it all the time. So there is some rules, and you should care about money, and you should think about how you can start your own prehabilitation business case. So today, I'm going to share you our story and how we did it, and why it is important to care about costs, how you can create your own prehabilitation business case, what we did in our prehabilitation randomized controlled trial, and I want to give you practical tips how to build your own prehabilitation business case. So yes, costs are important. There's growing healthcare costs, and that they are by far the greatest challenge facing hospitals. And these are some of the challenges. For example, $750 billion go to waste yearly in the US, and that's about 5 times the total operating budget of the NHS in the UK. Another example is from the Netherlands, where we see an increase in health expenditure per head of the society with more than 100% over 20 years. And there is many worldwide differences. Looking at the numbers of the McKinsey's Health System Interest Group, there's big differences between countries and within countries. So for an average treatment, for example in the US, you pay around 12,000 euros compared to the same treatment in Germany of around 3,600 euros. So that's a huge difference. And there's big differences too between countries. And this is an example of the UK, where there's an up to 60% difference in the same treatment between 4 different hospitals. Yes, care is complex, and is getting more complex by the increasing of our knowledge. It still brings high mortality rates, and we learned yesterday that there are still treatments with up to 50-60% of complications after surgeries and treatments. So it is important to talk about costs. But how do we do it? If you ask me, just move your ass and get the shit done. But that's maybe too easy to say. So let's get into detail. You're all prehab believers, and you're all smart, so I don't have to explain you the value of value-based healthcare principles or the triple aim. It's all about creating value for patients. That's why we are here. We have to look at outcomes that really matter to patients. Also the soft outcomes, divided by cost per patient. And looking at that cost, that's quite difficult stuff. We can do cost analyses, looking at cost-benefit analyses or cost-effectiveness analyses. And that appears simple, but it isn't. If you don't do that properly, it's really like comparing apple with pears. If looking at cost-benefit analyses, you go and look at the reward you really want to get, including all the costs that are in the treatment. So from development to implementation and to execution of your project. So what you're aiming for. If you look at cost-effectiveness analyses, you're comparing treatments with each other. For example, introducing prehabilitation versus regular care. And that's more used in healthcare because it's easier to compare and to get numbers easily. But it all depends on patient success and obstacles because every patient is unique and different. So let's get more into detail in the prehabilitation business case. It's not just a simple business case. You have to take care of the different silos that we know, and in this case on patient level, hospital level, and society level. Looking at patient level, what patients do is invest in their time. They have to pay their monthly insurance, and they will get some benefits if they do prehabilitation properly. The hospital needs to invest in costs in a prehabilitation program, in a treatment that they offer, and have to take care about or think about unexpected costs more later. And they may have direct savings due to a reduction in complications or length of stay. At society level, there will be development costs to introduce prehabilitation, community-based, for example, and there may be long-term savings that we do not really know, or non-tangible improvements like improvements in quality of life, which are quite still hard to measure. So if we have aligned this, and we plus and minus a bit, wouldn't it be easy to calculate your business case? I think it will not be that easy. Insurance companies, they don't know their role yet in how to deal with innovation, introducing new programs. Can they invest? Can they not invest? What are the real health benefits? And what is that converted into money? What about the unexpected costs? If patients are fitter after surgery, they might need more chemotherapy or additional surgeries. That will bring other costs as well. And what are the development costs when doing it in the community? We have to find out. The long-term savings, like a better quality of life. How do we define it? And non-tangible improvements. A prehabilitation business case is definitely not what it looks like. So let's get even more in detail. So the investment of patients, what I said, is time. It's not only the patients themselves, it's their caregivers, their family. They really need to get that lifestyle and mind change, and still have to pay the monthly insurances. They will have savings in the short term, getting back faster to their activities of daily living, but also in the long term, and may even have survival benefits. May that sum up as €0? We actually don't know yet. On a hospital level, it may even be more complicated. We have to invest in a prehabilitation program. I will get into that numbers pretty soon in the next slides. We have to look at the treatment that is given and how that is in proportion to what we do as well. We had example of the investment in robotic surgery, that it doesn't really deliver value to patients, and that we don't really have a business case on it, but that we still want to operate with it. And looking at the 1-hour operating theater of €1,000, it is similar to a 4-week program of prehabilitation. We have to define the unexpected costs, although that is depending on an individual patient. And development costs a lot as well. And we may have some direct savings, lesser complications. We know about literature how much that could be. Length of hospital, similar like that, ICU stay. And we may have lesser consultations and procedures of colleagues because a patient do better and can get discharged faster. And there may be less care needed in recovery. But is it like that? No, I don't think so. Less ICU stay may mean that a hospital gets less money because the bed is empty. So that may need other improvements or closing beds rather than it directly saves money. And the same for consultations and procedures. And then society level. That may even be more difficult to calculate. The development implementation costs, are they done within the society or is it being developed in the hospital? And does the society only benefit from what was being invested within hospital care. And there may be a lot of long-term savings which are hard to calculate. Less care that is needed in recovery phase, a long-term lifestyle change, secondary prevention, as been talking about in the Macmillan Cancer Report, secondary prevention, quality of life, earlier going back to work, less GP consultations of paramedics, less home and informal care. And what about insurance companies? If they have to pay less, they are getting rich. How do we get back that money so we can provide prehabilitation to more patients? So it is difficult, and I can see you scream, help, how am I going to do it myself? So maybe best to just get you through our story. And that started 2015. We went to our godfather, Professor Carley, to his laboratory, and he made me a believer in just 1 week. I got back to our hospital, we got our team together, a multidisciplinary team. We had a closer look at our care pathway, and we found out that we also had a window of opportunity if we were able to manage all the other consultations in the week or in the weeks before. So yes, we had a plan. We were believers, we had a team, we had a protocol, how we would like to do it. We had the full belief that we could give that benefits to our patients. So we had to convince our management. But they pointed us the door. Prehabilitation, we've never heard about prehabilitation. Do you think that that doesn't cost any money? And what is your business case? So yes, that was the point that I couldn't refuse talking about money anymore. So we went back, we talked with other managers, and we found one that really was on the same level as we were. She became a believer and she said, just do it. Start a pilot study with 50 patients, and that's what happened. We proved feasibility of the implementation of multimodal prehabilitation, that it was effective for patients and safe as well. During the pilot study, we gathered together with all the specialties that were needed to provide this care to the patients, and we biked for hours. And as you see here, our sports physician is the only one smiling after those hours. But that effort wasn't for nothing. We raised money and more money to further develop our ideas, to start an international trial on prehabilitation, and that's where we are now. And this might be interesting to you. To me, it's just numbers, but this is a translation of the protocol for our international trial. Because we had the protocol, it was easy for us to translate it and extract what we needed for human resources, program costs, or other fixed costs. And you see the results here at the right side for Canada and the Netherlands. And you see that the numbers are approximately the same. It sums up to this number. So if doing a prehabilitation program, a multimodal program, it will cost you around 1,100 euros in Canada and around 1,000 euros in the Netherlands. It may also bring you savings. So you're calculating your cost effectiveness here. Savings in a reduced length of stay, lesser complications, which may even sum up to over 3,000 euros, a little less in the Netherlands. So yes, prehabilitation can bring you money when done properly. And when just comparing one treatment with the other one, where prehabilitation is involved. So with these numbers and the proof of our pilot study, we had a chat with our insurance companies and got them convinced to support our prehabilitation program, to invest in the development costs, and to make appointments that they would further make this part of the insurance for those patients. We further launched the Fit for Surgery Foundation, and we published about our goals and our vision of the future of prehabilitation. And this is very exciting news. A colleague of mine from Amsterdam, she's working as a surgical resident, and she's doing her PhD this year, defends the end of this year in the Netherlands. And together we thought, okay, how can we translate what we did the past years as fast as possible to our patients. Because not everyone understands a randomized trial. They need to know what their motivation is, what they can do to make themselves fitter, where they can find the help, and how they can create their own fitness passport. So we found a Dutch publisher, and hopefully the end of this year it will be available in Dutch, and maybe later in other languages too. So if I may conclude about the prehabilitation business case, there's not just one case. You need believers. You need to adhere to the value-based or triple aim principles. And yes, you need some numbers, but they are easy to calculate. Doctors and managers think different, so bring those numbers to them. Costs are always in proportion too. So refer to a robot or other costs that are ridiculous. Think of patient, hospital and society level, and collaborate with your health insurance companies. You have to consider what calculation you will make and what cost analysis you will do. And think about the non-tangible benefits, because it's very hard to calculate what a quality of life in a number means for a patient. But a happier patient may even be more beneficial than like an increase on a scale of 10 from 5 to 6. My second conclusion is that prehabilitation is definitely value-based. We improve outcomes for patients. We did see happier patients. We empower them and giving them charge back on their treatment. They are less vulnerable. There is evidence now that they might have survival benefits, improved quality of life, and lasting lifestyle changes. I think we can improve our screening methods, but it needs some more research on that. We can improve our efficiency in the healthcare programs by prehabilitation. Yes, we offer them teachable moments, what we've heard in all the other talks. It supports the collaboration and medical leadership, and it improves resilience for treatment effects of the patients. And it will also get us to secondary prevention. And yes, prehab saves us money. So this is a slide I made you, which is a translation of our prehabilitation journey, and I hope that this will help you creating your own. Slides will be available after the conference too. So remember, please, prehabilitation is not just a business case. We bring business if done properly. So before I end, we had some dancing in the past years. I'm not forcing you to dance again today, but I want to make a statement. A statement that prehabilitation is not just about money, but that it's important to think about money, but not that it's all about money. So I want to ask you to stand up to show each other your money. So is everyone having his wallet with him? I brought some. Yes, much rich people in here. So can everyone show us his money? Yeah? Okay. So if you feel like dancing, you can dance. But I'm asking you this time to sing. Because if you know this song, you have to sing. And I bet you all know this song. So the song is all about money, but ends with that we don't think it's all about money. So please, show us your money and sing and dance. It's all about the dum-dum-dum-dum. Got it all wrong anyway. Thank you.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.